David Seltz is the first executive director of the Massachusetts Health Policy Commission, an independent state agency that develops policy to reduce healthcare cost growth and improve the quality of patient care.
Well, good afternoon, everyone. It is really a pleasure to be back here in Delaware talking about this topic with all of you and sharing my perspective. And I guess I just want to first say congratulations on all of the progress you are making on this really important topic. And I really want to commend all of the leadership of this state for doing this in such a deliberative process in bringing and engaging the community around how to create a more affordable and sustainable healthcare system here in Delaware. And I just want to commend it and thank you. I guess also want to thank the Medical Society for hosting Matt, Secretary Walker, and I think what you're going to hear from me is a little bit of a variation on the same story. And I guess one thing I would say at the beginning is you're going to hear from 3 states, and we all did this a little bit differently. There's no one right way to do this. And I'm a big believer in states being the laboratory. So however you decide how to move this forward, tailor it to your own state, to your own priorities, to your own stakeholders, but also learn from other states, because I do think that there is absolutely some lessons to be learned as you put this together. So I'm going to talk a little bit about the Massachusetts story here and the Health Policy Commission, which I'm the executive director of this agency that was established in 2012 as a brand new state agency overseeing healthcare cost containment efforts in Massachusetts. Backing up a little bit earlier than that, Massachusetts, we pride ourselves on being nation leaders on so many different things, and especially in healthcare. In 2006, we passed a landmark healthcare reform access law with the goal of making sure that every resident in Massachusetts had access to affordable health insurance. That law became, of course, the model for the Affordable Care Act 4 years later. But after we passed the access law, policymakers were really focused on how do we make this promise sustainable for the long term. Having said that access to health insurance is a right for our citizens, how can we make sure that we can afford that over the long term? And in Massachusetts during this time, and especially throughout the 2000s, our healthcare spending was growing at a very rapid pace. And by 2009, we had the highest per capita healthcare costs of any state in the country. And as we all know, the United States has the highest per capita healthcare costs of basically any developed country. So Massachusetts was the most expensive place on the planet to get healthcare in 2009. And the same impetus that you heard about before in terms of what brought us to this effort around healthcare cost containment was that crowding out effect. The crowding out effect that we saw in state government, where we were spending over a decade, basically, we spent 60% more on healthcare in our state budget and less on a per dollar amount for transportation, for education, for mental health services in our state budget. And of course, same story for our businesses and employers having to make decisions about being able to hire someone or give someone a wage increase or being able to maintain good health insurance coverage for their employees. And of course, down to families who were seeing what little wage growth that they were getting through their jobs going completely out of their pocketbook in the form of higher premiums, deductibles, and copays. So this crowding out effect really became the impetus for us to say, let's chart a new path. And the legislature, and I worked, just as a bit of background, I worked in the state legislature during this time, so was a part of the bill development process. And there was a lot of talk at the time about potentially even moving towards rate setting and setting up something that was going to be really a regulatory approach. And ultimately, the legislature kind of walked up to the cliff, looked over that edge, and then backed away. And really our reform effort is about making our healthcare market work better in Massachusetts, strengthening that private market, not in a government takeover type of way. And we don't have the same type of regulatory authority that even Vermont does, and that was just discussed. So we passed in 2012 another landmark bill. It was, I think, over 350 pages. It was the last bill that was basically passed during our formal sessions. It was larger than both of our state budgets combined. It was a comprehensive piece of legislation. And as you can see here, here's all of our state leaders joining together. It was a bipartisan bill, although our governor and the state legislature at the time were controlled by the Democrats. The Republicans who were in the legislature did also vote for this bill. And it was called an act improving the quality of healthcare and reducing costs through increased transparency, efficiency, and innovation. Doesn't that sound great? I mean, you can't argue with that at all. The law has a number of big goals attached to it, and they're exactly the same goals that Vermont was just talking about. Transforming the way that we deliver care, moving away from a fragmented healthcare system to one that's more coordinated, that's integrated, that puts together both the medical and the behavioral health care, and really is following patients from all the different settings of care, from the primary care to the hospital to the skilled nursing facility and back to home, and having the information and care really be patient-centered. The second was around how we change how we pay for that care. So moving away from the traditional fee-for-service model, you pay for volume, you pay for acuity, and moving towards paying for value, moving towards paying for the quality, and rewarding providers for keeping their patients healthy and out of the hospital. So moving towards more what we call alternative payment methodologies that really create the incentives for providers to do the right thing for their patients and not just continue to provide more and more and more healthcare services. The third was around our healthcare market. And again, we still rely on private negotiations between our insurance companies and our hospitals and providers to set their reimbursement rates. But we do know that in many cases, those reimbursement rates are not necessarily tied to the quality of care that those providers are providing, but rather due to their size, their market leverage. And so we wanted to make our market work better and actually reward the providers who are providing great value. And then finally, a real goal around more information. I use the word purchasers here. That's really kind of code for employers and consumers to say, how can we get real-time information into the hands of these decision makers about where they seek their care, what that care could be, and provide much more transparency in terms of the price and quality of care being delivered. All of these strategies are kind of underneath the surface, and they're all working together towards our goal. And our goal here is a healthcare cost growth benchmark. This is kind of the organizing principle of our entire effort. This benchmark is set basically tied to the long-term growth of our state's economy. And so again, the goal here was to say, let's limit this crowding out effect that we had been seeing going on. Still growth. Of course, growth. We need to be able to invest in our important healthcare system, but maybe not at the same rate that it was growing at the same before, and to create a more sustainable rate. Importantly, this is an all-in measure. This is Medicare, commercial spending, Medicaid spending, and it also includes the out-of-pocket spending that patients and consumers contribute towards our healthcare system. And really, the reason why we wanted this to be all-in is because everyone who knows and has worked in healthcare, if you just push down in one area, it's inevitably going to pop up in some other area. So we needed to have a full, comprehensive view of healthcare spending in Massachusetts. This is just another slide, a little bit about how that target is set. As I mentioned, it's tied to an economic term called potential gross state product. Essentially, it's a long-term goal of the state's economy. It was initially set in law at 3.6%, and then there's actually a process every year where that's updated. And we have a process in Massachusetts where the administration and the legislature decide together, basically at the beginning of every year, what they think the revenue growth, the tax revenue growth is going to be. And so that statute was amended added an additional responsibility that the legislature and the administration every year will update what this target is. Since it is really supposed to be a long-term growth target, it may not surprise you that it is maintained and has maintained at 3.6%. So every year they do look at the economic data underneath that, have the opportunity to update it, but they kept it at 3.6% over the last 5 years. So to help the state be able to track and monitor our ability to hit these benchmarks and to succeed in the goals that I laid out before, there was 2 state agencies that were established in this law. The first is called the Center for Health Information and Analysis, and it has a great acronym, CHIA. And this state entity was actually an entity that already existed. So this was not a new state government entity. It was previously called the Division of Healthcare Finance and Policy. It was an executive branch agency. It moved to become a little bit more of an independent agency, but really was an agency that already was there and had staff and operations. And the other agency that was created was the Health Policy Commission. And this was created from scratch, and there was no kind of existing infrastructure. I was the first employee of the Health Policy Commission. I had to figure out how to order computers and fax machines and copiers and office space. And so really a startup in a lot of ways. And the division between our 2 state agencies, and we work extremely close together, is that CHIA is really the data hub for the Commonwealth. They collect a tremendous amount of information from our health insurers, our hospitals, our physicians, and take that data in, clean it, and analyze it to be able to make that data available, not just for the Health Policy Commission, but for the states as a whole and many other state agencies. But really just a data hub. And the Health Policy Commission is the policy hub. And this is the place where we take that data, interpret it, and be able to make policy recommendations from it that can help us achieve our overall goals and help us hit the benchmark. So I'll talk a little bit in detail about the Health Policy Commission. I think it's most relevant, obviously, to your conversation. I think as I was being introduced, you heard about who we are, our mission, and our vision. I think importantly, our goal is better health and better care at lower costs across the Commonwealth. I think that's a goal that every state should have and does have. And our structure is unique as well. So I'm going to spend a few minutes talking about the structure and some of the lessons learned from this. So it is an independent state agency, and I report to a board. The board is made up of 11 members who are appointed by the governor, the attorney general, and the state auditor, each of whom are independently elected constitutional officers in Massachusetts. As you can see, we did write into statute that each board member does have a specific area of expertise. And so you can see we had someone who was a primary care physician written into the law, someone who's an expert in behavioral health care, a healthcare economist, someone who can represent consumer advocates, and you can see all the different levels of expertise, really kind of spanning all of the different areas that you would want to have represented on a board like this. Notably, the board members were appointed in staggered terms in their initial term. So board members were either had a 1-year term to begin with, all the way up to 5 years, and then could be reappointed for an additional 5-year term. And the purpose of that was to really have it be so that the board is not turning over all at the same time, and it wouldn't be tied to, say, an election occurring that all of a sudden the board is turning over. It really is supposed to be kind of 1 or 2 board members, potentially a year, moving on. As you can see, no one of these constitutional officers maintains a majority of the board in their appointments. The governor has the most appointments, 5, but 6 is the voting majority. We do have 2 ex officio members who sit on the board and are voting members, our Secretary of Administration and Finance, our County Budget Office, as well as the Secretary of Health and Human Services who do sit on the board. The chair of the board is a long-term healthcare economist in Massachusetts. His name is Dr. Stuart Altman. And he really came to this with just incredible credentials and a long history of working in healthcare. And so he is the board chair by statute. And importantly, the legislature did not want to have one of those ex officio members being the board chair. So the ex officio government appointees are there as voting members, but they're not labeled in law as the board chair. We included very strong financial conflict of interest restrictions when it comes to these board members. So no board member by law can have any financial interest in the healthcare system. And as you can imagine, this created some challenge in finding appointments and people who have these different levels of expertise who are completely financially divorced from the healthcare system. Many of the board members actually would serve on boards for hospitals or insurance companies, and some of them had to remove themselves from those boards in order to participate. One interesting kind of side note here is we had a primary care physician who is a board member, but the primary care physician could have no financial interest in the healthcare system. So that created a unique challenge, maybe an unintended consequence, because basically that meant that any practicing primary care physician would inherently have a conflict. What we ended up, we had a great board member here who was a retired pediatrician, and so that's how we kind of worked through that. So like Vermont, it was really important for us to have an independent board and not to have the board be made up of, say, the head of the hospital association or the head of the Association of Health Plans or, candidly, the head of the medical society. We wanted these board members, just like Vermont, to not be sitting there representing one specific element of the healthcare system, but really be taking that broader view about what is in the best interest. Yes, coming to the board with expertise and experience that they would lend to that, but really not there representing one particular stakeholder, but really there to represent all of the residents of the Commonwealth. The board governs through consensus. I think we've had 5 years. We just celebrated our 5-year anniversary. I think in that 5 years we've had one no vote among our board members. So it really is a place where there is a dialogue and an effort to try to find compromises and work together to advance the goals of the agency. A few other things just quickly about kind of the structure here. So the board does appoint the executive director, that's myself, and I oversee the staff and run the day-to-day operations of the organization. Recognizing, again, very similar to Vermont, that while we have this independent board, we really wanted to be able to have connections with all of these important stakeholders. So it wasn't like we didn't want the perspective of a hospital association or the medical society. And so the law set forth that the executive director could establish or should establish an advisory council that I meet with regularly. And that advisory council was given kind of broad discretion to me in terms of who I could appoint to that. I have a 32-member advisory council made up of just about every different perspective that one could imagine in healthcare. And we meet about quarterly and talk about the priorities of the organization and get input. Again, like Vermont, this board is subject to open meeting law, so we conduct all of our deliberations in public. Really important, really crucial. And just as was said before, really created a place where the public and all of the stakeholders and everyone who has an interest in there knows where the decisions are happening, knows that they can go to these board meetings, and all of our board meetings are public, and see and contribute to that decision-making process. And so transparency in how we conducted our work was extremely important and one of the strengths of why we've been able to be successful. I just did the math. In the last 5 years, we've held over 200 public meetings. That averages out to be about 3 a month. And it's a lot of work. It's a lot of work to put on, 3-hour public meetings just about every other week with, 100-page PowerPoint presentations that go up on the website. And we have about, I would say 150 to 200 people that regularly attend every single one of our meetings. In addition, we live stream all of our meetings and all of our materials are public. To kind of manage, we do have a larger board, so it's 11 people, a little bit different than Vermont. One of the things that we did to try to have an ability to kind of deep dive on some specific policy issues is we established some subcommittees. So the board has right now 4 policy subcommittees that are made up of 5 members, so each board member is on 2 subcommittees, and they really kind of do the deeper dive on some particular policy issues, and then we'll advance them up to the full board for consideration. And that was a way that we could really have more focused conversations with a smaller number of the board members, while also still elevating it up to the board level. This is really our tools in our toolbox, and they're varied. And depending on what the issue is or the problem, we use different ones. So one is we're a researcher and reporter. As I said before, we take that data that SHIA collects, we publish an annual report about where we are in terms of our ability to hit that benchmark. How and why are we hitting this benchmark? I think one could imagine a scenario where, yes, you're able to hit that healthcare cost growth benchmark, but actually do real harm to patients or to the healthcare system. So it's important to understand why or why not we're hitting that benchmark, and to be able to use data and objective facts to be able to identify where are those opportunities to get efficiencies in this system that will provide better care and value to patients. So researcher and reporter is a big part of what we do. The second thing is a convener. We don't have all the answers in government, and so part of what we do is we bring together communities just like this and come together and say, how can we work together on some of these big challenges? And it's not coming from a situation where we're telling the healthcare market how to do this, but really let's work together. And that's a big part of how we've been able to advance our agenda. The third thing that we do is we are also a watchdog. And so sometimes we do identify market behaviors or individual organizations that are excessively contributing to healthcare spending. And that can be something where we are calling out dysfunction in many cases. And then finally, we're also a partner. We have, a part of our responsibilities is actually giving money. We do grants, we do investment programs, we certify provider organizations. So we want to work together with providers to be able to meet our goals as well. I'll show you, this is just a little bit about our organizational structure, and I don't want to scare people by how many employees we have, but we're up to about 60 employees at the Health Policy Commission over the last 5 years. And the reason I don't want to scare people too much is because we do a lot of different things. We have a whole part of our organization that is certifying accountable care organizations and patient-centered medical homes. We have a whole part of our organization that is just doing grants and investments in our healthcare market. We have a part of our organization that is reviewing hospital mergers and consolidations to try to understand what their impact may be. And then, as I mentioned before, a department that's really focused on the research and identifying how we're doing versus the cost. And so, to give you kind of a better sense of how this breaks out, this is kind of full payroll and consulting services among those different categories. So, depending on what you want this organization to do, you can imagine that it might be much smaller than what I just showed you. And you can kind of see how those different pie slices play out in this particular, for our organization. I would also note that the Center for Health Information and Analysis, the CHIA, our sister agency, they have actually gone through a period of retrenchment in terms of their budget. So if you combine CHIA and our budget together, there has not been additional healthcare spending on those two state agencies kind of netted together. Their budget has actually gone down by about $10 million, as our budget has gone up by 8.5. So in terms of total additional spend, there hasn't been. Our spending, our budget is funded through an assessment that is levied on hospitals, ambulatory surgery centers, and health plans. And it is split up basically 50-50 between the hospitals and the health plans. And they contribute to the state basically and through an assessment collection that pays for our operations. So we are not funded by taxpayer dollars. And again, I think an important thing to consider how you set up the financing for an organization. That has allowed us to not have to kind of necessarily be worried every time that there's a budget shortfall. It provides us much more stability in terms of being able to plan a long term for our operations. And also, I think interestingly, provides an interesting connection to our hospitals and health plans. I think we kind of take it pretty serious that they're the ones paying for us. And so we better be providing value to this healthcare system. And we do think about that in terms of how we set our priorities. We're funded by the industry. So we need to be working with the industry to make sure that we hit our goals. I mentioned here, these are kind of the four big things that we do. Monitor the cost drivers in system transformation, make investments, especially into community hospitals, promote a more efficient delivery system through some of our certification programs. And unique to Massachusetts, we do have an ability to examine market acquisitions, consolidations, joint ventures, not from an antitrust perspective, but really from a public interest perspective. The academic literature is quite strong that hospital mergers can lead to higher prices, and so we have a transparent way of reviewing and making public what we think the impacts of our rapidly consolidating healthcare system will be. All right, so I'm going to show you just some results, and then I'll stop and take some Q&A. So on the top part of this graph is, you guys are all very familiar with this now, this is the CMS per capita dollar amounts. On top was 2009, we were number 1. 2014, no longer number 1, we're number 2. So we're right ahead of you in number 2, and I would note Vermont's number 4 on this list. But interestingly, it wasn't necessarily that everyone kind of caught up to us. We did have a very different spending trajectory over the last couple of years. And so here you can see that from 2009 to 14, we had the 4th lowest rate of growth in healthcare spending. Delaware grew at the 7th highest rate. So you can see our little orange bar all the way to the left there. Here's another way of looking at it. This is, again, kind of growth in total healthcare expenditures. The blue line is the United States, the orange line is Massachusetts, and you can see all throughout the 2000s, we were growing much, much faster than the United States. And really around 2010, you can see we have now consistently been growing at a much lower rate than the United States. And here's another way of looking at this, which I think is kind of interesting. This is just commercial healthcare spending. So think of your employers, your residents, their premiums. Again, orange line is Massachusetts, blue line is the United States. Since 2013, we have been markedly lower in commercial healthcare spending growth, and the delta that we have saved is $5.5 billion between the United States and our growth rates. So one last final thing I guess I would say is our challenges remain. As I mentioned before, we're still number 2, and we're a high-income state. And so sometimes people will argue, well, we're a high-income state, so what if we spend a lot of money on healthcare? Well, we looked at this as well, and this is just a graph of all the different states. And you have your income, median income on the bottom here, as well as the per capita healthcare spending on the side. And yes, there is a relationship, as you can see, between median total income and what you spend on per capita healthcare. But Delaware and Massachusetts, we are on the wrong side of that goal line. And so we definitely have our work cut out for us. So I have a ton more slides. I'm not going to go through all of it, so I'm going to stop now and open it up for questions.
Tom Trezise, as you move, I know Massachusetts is on a journey from a treatment to a wellness model, and from sort of precision treatment to precision wellness. And when you think about people then, they're going to probably consider themselves patients less than 5%, probably less than 1% of the time. So what's your strategy, your people engagement strategy of changing the conversation from patient-centric focus to consumer-centric focus?
So I think a couple of things. One, we are in the process of moving our entire Medicaid program to an ACO model where the providers will be at risk for kind of managing the budget of those populations. And we're through the federal government, investing a lot of resources into population health strategies. And again, it's really moving the mindset away from this is my patient panel to this is my community. And what are the health needs of my community, and how can the healthcare system, how can our hospitals work much better together with community-based organizations, with other healthcare organizations that are not the acute care facility, and really also getting even further upstream and thinking about the social determinants of health. Our healthcare is not actually that big of a determinant in whether we're healthy or not. And so how do we kind of change the flow of dollars and the focus away from just kind of the institutional setting to more of this community basis. And so we are kind of at the very beginning of that journey, frankly, but one where it really is trying to kind of avoid the over-medicalization at some points of our system.
You have
I can take one.
Yeah. Is there anyone else? Okay, go ahead.
Hi, I'm Ann Pesky with the Healthcare Commission, and I wanted to ask you about Massachusetts is known for its medical schools and its teaching hospitals, world-class teaching hospitals, world-class public and private universities, both of which, not only they create jobs in the healthcare sector, they create jobs in the medical device, in the pharma sector. So how are you balancing out that? Look, we're a job generator. We help really grow the economy of Massachusetts, balancing that with trying to hit less than 4% annual growth.
It's a great question, and really was one of the biggest tension points in putting this effort together. Healthcare is the #1 employer in Massachusetts. It is big business in Massachusetts, and as you mentioned, we have world-class institutions where people fly from all across the country to go to our institutions. That is creating all types of spillover effects in terms of research and innovation and life sciences and the biotech field. So this effort is harder than even the healthcare access effort. The healthcare access effort in Massachusetts was how do we get 500,000 people health insurance? Well, we can help them buy it, we can get them on Medicaid, and we can incentivize them to buy it. This is around a $60 billion a year industry in Massachusetts. And so it does need to be done thoughtfully and carefully, that we're not destroying or hurting one of our key strengths. And there was a lot of debate when the bill was being passed about where do you set that benchmark? Where do you set that goal? And there were some efforts who said, why would we let the healthcare system grow at 3.6%? There's all this waste in the healthcare system, we should let them say we can let them grow at 1%. There's a whole constituency, like we should set the target at 1. And as you can probably imagine, the hospitals and the medical society said, how about like 4.5%, 5%? And so it ended up coming, obviously somewhere in the middle. I would note, since the law has passed, we have not seen any impact in terms of employment or jobs. We continue to be, number one NIH state. But there is a balance, and it's one that we kind of constantly have to think about. And I think the other thing that we always talk about is, great that we have this incredible, system, but it can't be at the expense of every other sector. And so if every other employer and business and, resident is subsidizing this extremely expensive system, we're not going to have anything but healthcare. So it is a balancing effort for sure.
We have one last question.
It's like 1.5 questions, I guess. Was any consideration given to tying the benchmark to something other than the PGSP? And what were they? Why were they dismissed? And just if you could just quickly, with your opinion or any measures you might have, you mentioned the goal of universal access in Massachusetts. Is that been impacted at all by the fact that you're spending less than maybe you would have been otherwise?
So through our process, we had some economists who were kind of advising the legislature. So there were actually pretty good consensus early on around using that kind of economic growth rate as the foundation for the target. And as I mentioned, people wanted to say that minus 2 percentage points, that plus 2 percentage points, so there was a negotiation around it. I'm pretty actually agnostic about what you use. You could use an inflationary measure, you could use a regional measure. The important thing is just to have a target. It created this ability for everyone to work together and to have a common goal in mind. And that, just having an organizing principle, where you set it is obviously extremely important and what you tie it to, but the most important thing is just to have a goal that everyone can work towards. So I would advise not getting necessarily too caught up in what exactly the measure is that you want to use. The second, what was the second part of the question was?
Has access?
Access, yeah. So no, we continue to be the highest covered state in the country, the lowest on insurance rate. And I would mention, and I didn't show it here, but in terms of our ability to hit that benchmark, we've measured ourselves 4 years against that benchmark. First year was 2.4% growth. Second year was 4.2. Third year was 4.8. And the fourth year was 2.8. If you average all of those years out over that period of time, you get to 3.55%. So I have to go to that extra decimal point in order to hit it. But we haven't hit it every year. And I think that's okay too, as long as you kind of think of this as a long-term strategy. And the years we didn't hit it, pharmaceuticals.
Thank you, David.
Thank you.
I'm sure there are more questions.